space. To begin with, I would like to invite Dr. Zain Khaitab. If you can just switch on your camera, Dr. Zain, and you can unmute yourself.
Good morning.
And now I would like to hand over the virtual dais to you so you can invite our set of speakers. Thank you.
Thank you so much. Good morning to everyone. Welcome to our Young Masters Instruction course titled The Skewed Topography of a Young Refractive Surgeon on this very exciting virtual AIOS 2021. And with me, I have a group of young, dynamic refractive surgeons who will all be sharing their experiences as newbies, their struggles, their challenges, and this entire course will be focused on how a young refractive surgeon finds their feet, in a large city. This course is under the banner of Mumbai Young Refractive Surgeons Association, or MIRSA, which is a recent initiative started by us where we help and support each other and help each other in refractive work. So before we start off, I would just like to say that each speaker would be speaking for roughly around 10 minutes. After that, we'll have a short time for discussion, and if time permits, at the end of the talks of all speakers, we'll again have a discussion. So without wasting much time, let me invite the first speaker, that is Dr. Prajakta, who will be talking about her journey from fellowship onwards into private practice. Dr. Prajakta is a consultant cataract and refractive surgeon at Shankara Eye Hospital in Navi Mumbai. Dr. Prajakta, over to you.
Thank you, Dr. Zain. So I'll just share my screen. So are my slides visible?
Yes, your slides are visible.
Okay. So again, good morning, everyone. I would like to thank Dr. Zain for putting up this interesting IC. So my topic for today is fresh out of refractive fellowship and what is the way forward. So I'm sure this will be quite a relatable topic for people who are into a refractive fellowship, because they can just see what is waiting for them outside once they're done with the fellowship. And also for people who are planning to enroll into the fellowship, because if they have a fair idea about how the fellowship is going to take them forward after they are finished with it, then they can take an informed decision. So I have no financial interests. So I would like to begin by saying what is my opinion is that fellowships are a must. I think some of you will differ with this opinion, but what I feel is fellowships are a must, because nowadays there is a lot of patient awareness. Many patients want to see a specialist doctors nowadays. Earlier, ophthalmology was considered like an end branch, but now, unfortunately, it is not so. So we don't want to cut a sorry figure when a patient comes to you and say that, okay, are you not a specialist? I want to get my treatment done from a specialist. So I would, that's why my opinion is that fellowships are a must. So again, what kind of fellowship you do, what are the plus points that lure you towards the refractive fellowship is that it is, from the outside, it looks very glamorous. Plus, it is not that surgically demanding as compared to the other fellowships. Plus, the overall duration, if we see, doesn't go max above 1.5 years, in contrast to the other subspecialties, which is at least minimum 2 to 3 years. So again, you say, okay, even if we have to do a fellowship, let me go for a refractive surgery fellowship. So because of peer pressure and all the competition around you, you do some search that which institute gives you a better option and all those things. You talk to your colleagues and you finally enroll for a refractive fellowship. So it's done, whatever was your training is completed, and here you are with a certified refractive surgery fellowship in your hand. But what next? So the mantra of success for this is to each his own, because refractive surgery is one kind of a subspecialty where you can't go by a set protocol. So it depends on what the different factors which we'll be discussing all throughout this IC. So taking into consideration all these factors, then you can take your own decision at the end of the, after taking into consideration all the factors. So there are two ways of looking at it. One is welcome to harsh reality. So this is a common word if you go and ask any of your seniors as soon as you're just out of your fellowship and you talk to them as to guide you as to what is a way forward. This is the first thing that will come out of their mind is welcome to the harsh reality. But don't worry, we can just take it in a positive way also, saying that now you are the boss. So whatever knowledge you have gained till now, it is now your call to apply it. You're not answerable to anyone. It is your patient. You can take a decision about the surgery. So before going about what kind of practice you want, you have to answer these three questions. First is when, second is what, and third is where. So for answering the question of when, you need to consider these 3 points. First is you have to ponder, was the training adequate? Refractive surgery, like I said, is not very surgically demanding. Even if you get less number of surgery chances, that's still okay. But it is more about diagnostics and the planning. So your training should be where you must have, you will have got adequate exposure about the different planning platforms, about the different diagnostic machines that are available. If tomorrow if a patient comes to you with a different topography report, you should have a fair knowledge about it to take a further decision. So just think whether your training was adequate. If it is not, then maybe you have to spend some more time with somebody who has a proper refractive setup and do a small observership over there. Secondly, you have to see whether you have finished your any personal commitments, because by the time you finish your refractive fellowship, you have already crossed the so-called age limit of 30 years and your parents have lost the patience already. So they would obviously insist on taking care of your personal commitments. So just have a look about that. On a lighter note, there's also a dream vacation if you would like to go, because once we step up into our practice, unfortunately, there is no retirement in medical career. So probably you might have to take this up, take a break, go on a vacation, and then you can come back and plan what are the logistics you want, and then you can start your practice. Second option is second thing to think about is what. So what kind of practice you want, whether you want a group practice or you want a single surgeon practice. So if you want a group practice, the advantage is that you don't have to take the stress of the capital alone. The investment will be between the groups of people that you're going to work with. But the disadvantage is that the group practice should be among the like-minded people. If at all in future some colleague of yours tries to interfere in your domain, then the relation becomes a little sour, and then the practice might fall off. Then versus that, you have a single surgeon practice. So as a single surgeon, the advantages is that you will bear the entire fruits of your efforts. It will take time, definitely, but it is only you who will get all the benefits at the end of in the long run. But again, there are disadvantages that you will have to make the entire investment yourself. You will have to put all the protocols in place by yourself. Again, you'll have to take a look at your bank balance, whether it is visible or no. You will have to go and look for people who can help you with your venture. But in the long run, this will definitely is rewarding. Then another thing what you have to look at is, do you have a ready setup with you or no? There are some people who already have a ready setup at your place, but still you can't just go and sit in the setup and say that, okay, from tomorrow onwards, I'll start getting my patients. In that ready setup also, you will have to find your niche, because so many years down the line, maybe your mother, father, whoever setup it is, people have been trusting them blindly. So for them to build a trust in you will again definitely take a time, but still the transition will be a little smoother compared to people who will not have a ready setup. So for people who don't have a ready setup, there are different options available. First is like an eye institute. So again, the advantages is that the investment, everything is done by them. It's everything already ready in place. You just have to go and start utilizing it. But the disadvantage is that there is little less scope for experimenting. The growth will be little slower, And of course, in the initial this thing, the name, the prospering of the name will be of the institute rather than you as a surgeon. But again, it will have a steady income. So that is one option. Second is a multi-speciality hospital. Nowadays, many of the multi-speciality hospitals are investing in the ophthalm department. They have now considered it as a major branch, and now they are ready to invest in that. So you can be a part of that. But again, they will have a set of corporate goals to attend. So maybe in the long run, you might have to sometimes take some decisions which are against your will. So that will not give you a job satisfaction. But again, this will also give you a steady income. So if you're willing to compromise that much, you can do well in the multi-specialty. Third is the private and group, like we just discussed right now. In a private practice, you can also do something nowadays, which we have is like a neutral center. So you can just examine your patient in your OPD. You don't have to invest in the machine and the diagnostics. You can take your patient to a neutral center where you can operate and do the diagnostic part. And then again, the follow-up part can be done in your clinic. Then lastly, we also have option of freelancing, though this is very rare. But you can go around, see general practitioners, you can meet with them around you, and then you can just tell them to call you for this. If you have a good rapport with them, that also can be one option.
May I request?
Lastly, you have to look at is where do you want to set your practice. So for that, you need to do a thorough market survey. So if there are like well-established refractive centers in 5-10 kilometer radius of your clinic, then that may not do well. Also, you can't just go to a rural place and say, okay, there are no refractive surgeons here, I'll start my practice here. But that also won't work.
Prajakta, you can sum up in 1 minute.
Yeah, patients that are not affordable. So do a market survey for that. And lastly, I would like to say that keep yourself updated, because refractive surgery is a ever-evolving branch. So you have to be abreast with all the current knowledge that is available. The refractive patients are young patients. They have a liberal access to social media, so they can either make you or break you. So you have to deal with them very carefully. And ultimately, even though so many things are there, but don't give up, dream big, aim high, and everything will automatically fall in place. Thank you.
Thank you so much, Dr. Prajakta. May I request Dr. Zain to please invite the next speaker. Thank you.
Oh yeah. So Prajakta, that was a very good talk. Do the panelists have anything to say, or any comments or any questions?
I think we can do it at the end of the things when we discuss all together.
Fine. Okay, our next speaker would be Dr. Neeraj Israni, who is a good friend and a colleague. Currently, he's working at Sharda Nethralaya Dhule as a cataract and refractive surgeon. He will be talking on managing finances and refractive surgery. Neeraj, over to you.
Good morning. I hope everybody can hear me.
Yes, loud and clear.
Okay. So thanks to this amazing platform, Dr. Zain Khatib, for organizing this IC. Thanks to AIOC for giving me this opportunity. So the topic that I've been given is how to manage finances in refractive surgery. So before I start my presentation, I just want to say that I'm probably still a neonate in refractive surgery, and it's still a long run, and I have to learn a lot over time. But I'm soon going to start my own private practice. So I have been also trying to research about refractive practice, since I'm also a refractive surgeon. And I'd be happy to share whatever little I know and whatever little I've researched about finances in refractive surgery. So this is my first slide, which says a reality check. So I believe that not every doctor is a good businessman, and every doctor should definitely have a reality check. We as doctors always believe in volume. So let's say, for example, a private refractive surgeon is performing, say, 20 to 30 LASIKs in a month. But if you compare it with an institute, the institute performs at least, say, 70 to 100 in a month. So volume is something which I believe is just vanity. Next comes gross profit. one has to understand, or one believes that gross profit is respectability, but actually net profit, that is the cash in hand or the cash in bank, after all your expenditure is minus from your gross profit, that is reality. So again, gross revenue versus net revenue. Net revenue is what is actually important for everybody, and that is what we need to understand. The reason why refractive surgeons buy refractive platforms. So suppose if a refractive surgeon is given a sum of 3 or 4 crores, the refractive surgeon will opt to buy a LASIK or an examiner machine. Whereas if you give it to any other common man, he would rather invest in gold or diamonds, say for his spouse or for himself, or if the person is a little on the insane side, he would rather invest it in a Ferrari. But the reason I would rather invest as a refractive surgeon in an excimer laser is because this machine, which is costing me 3 to 4 crores, will further fetch me 3 to 4 crores in the next, say, 4 to 5 years down the line. So we have always been taught that medicine is a combination of science, art, and commerce. And science is something that we are taught. Art is what we are expected to practice, but commerce is something that nobody talks about. So the reason certain refractive surgeons are buying machines these days, one of them is vanity or stupidity, like I've already said. The other one, which is again on the rise, which is compulsion or peer pressure. But the main reason that one should actually purchase a refractive platform is profitability as sole purpose. Now, moving ahead, when we talk of cost of any procedure, say LASIK, we have two different types of costs that we need to consider. One is the fixed cost, which basically consists of infrastructure, equipment, and salaries. The other one is variable costs, that is your co-management charges, consumables. We can also see this from the aspect that of direct cost and indirect cost. Direct cost will include cost of equipment, consumables, your advertising or marketing, and indirect cost will include staff, salary, apart from that, maintenance, repair, overheads, etc. So let's talk about fixed cost in refractive surgery. So if you want to purchase a good reputed platform along with a microkeratome, consider it to be around 2.5 to 3 crores. A good femto, say 3 to 4 crores. And if you want to go for a smile, then 4.5 to 5 crores. Along with this, you need a well-designed compact space for your OT with 100% power supply, dehumidifiers, and air condition, which needs to continue running all the time. So that's another 10 to 50 lakh rupees. Another fixed cost that one needs to consider is your pre-operative workup or topography is a must, which ranges from 10 to 50 lakhs. Dry eye diagnosis, as we know, it's become extremely important to diagnose dry eye before any refractive surgery, another 10.16 lakhs. If you already have a OCT posterior segment, you can have an anterior segment attachment, or you need to purchase an anterior segment OCT separately, which is again 30 lakhs. Variable costs. So let's talk about consumables. A standard consumable cost for one procedure of LASIK ranges from 6 to 10,000 rupees, which includes blades, customized treatments, etc. If you want to go for a Presby LASIK, that's around 20,000. Femto LASIK is 30 to 50,000. Also consider your post-op visits, enhancements, and repeated pre-operative workup for patients. Again, hidden costs are something which nobody talks about. A refractive surgeon usually gives 20 to 30 minutes of counseling to his or her patient. So that is chair time, pre-operative workup time, pharmacy in your clinic, enhancements, post-op care, follow-up. So these are all the hidden costs. Now, thanks to Dr. Rohit Modi for giving me this slide. He called it the Marwari thumb rule, but I'm a Sindhi, so I call it the Sindhi thumb rule. So according to the Sindhi thumb rule that I've worked up with him, every machine that you buy, there is at least 1% per month depreciation, further 1% per month interest on capital invested. So suppose if you're investing 35 lakhs on a Pentacam, you need to, you can just put that money in the bank and the bank will give you 1% per month interest on that amount. So total 2% at least return per month should be from any machine. So let's take an example. Like I said, suppose if you take the Pentacam, which costs approximately 35 lakhs. So let's multiply 2%, that is 0.02% into 0.02 into 35 lakhs, that's approximately 70,000. So unless you're sure that you can perform 23 to 24 scans, keeping into mind that a normal scan is costing around 3,000 rupees for both eyes, please don't buy this machine, or please don't go for refractive platforms. So if you see, this is a small table that I've prepared. The cost of a machine and designing space approximately will cost you 2.25 crores. EMI on that for 5 years is 5,20,000 rupees. Marketing cost another 50,000 rupees. Space rental and overheads is another 1 lakh. Staff cost of around 20,000. CMC after 3 years will be 1,70,000. So a total fixed cost per month is around 8,60,000. Now, removing the consumables and excluding those, you need to actually perform 33 patients or 66 eyes. That's the total number of eyes that you need to perform to break even the total amount that you're investing. And once you break even, if you reach these numbers, you can also do a total revenue of 11.8 lakhs. That's the calculation I've done. So lastly, I want to say that, again, as I said, that we doctors don't believe in numbers. We believe in surgeries and volumes. But this is something which I feel is very important and everybody has to understand. Profit equals to revenue minus cost. So if you want to increase your profit as a refractive surgeon, you have to increase your revenue or decrease the cost. So I want to conclude by saying that refractive surgery is actually economical and it is viable if you plan well, and you can measure your expenses and plan accordingly and still have a very good, thorough refractive profession. So remember, you are the brand and you decide how well people know about your practice. Thank you.
Thank you so much, Dr. Neeraj. Dr. Zain, you can take over, please.
Excellent talk, Dr. Neeraj. Very comprehensive. I think covered most of the points. I think, one of the things you kind of missed out or got wrong in your running costs, the CMC plays a much bigger role than what you mentioned. So I think the CMC ranges from around 20 to 30 lakhs for a machine.
So for
and
the
the
first
AMC,
3 years, maybe for the first 3 years, these days, a lot of companies are waiving off the CMCs and the AMCs. But of course, after 3 years, it plays a big role.
Yeah. So what happens is for the first 3 years, you're paying the EMIs for the machine itself.
Yeah,
so then the CMC, once it the CMC comes into play, your EMIs are done. So ultimately, you are having running costs all the time. So that does come from. Another thing which I would like to ask is, are there running costs for customized treatments? I don't think that there are running costs for customized treatments.
Customized treatments come in the form, so depends on which machine you're purchasing. I believe there are certain platforms that charge extra for customized treatments. Say, for example, Streamlight is charge extra, Contura is charge extra. That's what I meant by customized. However, there are certain platforms which have.
No, so I don't think Contura is charged extra. The Streamlight is charged. Yes.
So if you want to purchase a Contura, you have to pay extra for it. That's what I meant by
right.
On the Wavelight machine. Yeah.
Any of the other panelists have any comments?
Yeah, so I think even for your Contura, if you want to upgrade Wavelight, you need to invest in a topolizer and your whole suit. So it just adds up. for everything.
And another thing is, someone who is starting refractive practice, I really don't think you need to invest in a very, a pentacam or a very hi-fi machine like, a MS39 or something, or even probably dry eye workup. You can go in with a Placido topographer and an ultrasound pachymeter when you are starting off. So, that would come to like, within 5-6 lakhs. So that is something to think about for someone, who
And
doesn't want
also
to spend lavishly.
important thing is the space constraints, especially in a city like Mumbai, to have that infrastructure to install your machine. The space requirements are high, and as he said, costs of your ACs and your OT maintenance, those just are the bigger hurdles, I feel.
Right. True. Anyone else has anything to say, or we can move on to the next speaker?
I wanted to ask one thing, like you all just mentioned about the customized treatments. So is that a one-time cost that they take for the customized, like if I want to buy a Streamlight, so will it be a one-time cost, or again every year they have to, like I have to pay for it?
Streamlight is charged per procedure. So if you want to perform one set of Streamlight, you need to pay that X amount of money to the company. So it's not a one-time charge. It comes in the form of a card. You need to insert the card in the machine, and then every time you need to recharge or top up the card for Streamlight.
Streamlight is per procedure, and Contura is not per procedure. You have to buy the machine, but then the machine also works as a topographer. So, you can use that as a topographer, and you don't need to pay extra for each individual case.
Yeah, and then I think the Contura machine can also help for the in-tax planning and all that also.
Right, for everything, yes. Right, so we move on to our next speaker, who is Dr. Palak.
Then I need to ask you one thing.
Yes.
So for Contura, you don't need to have a card system. You can do.
Yes.
Like,
you don't need to have a card system for
there's
Contura.
not fixed number of cases. You can go on and.
You can do as much as you want.
Thank you.
Okay. So our next speaker will be Dr. Palak, who is working at Arihant Netralaya, Nagpur. And she will be talking to us on the role of phakic IOLs in a beginner's refractive practice. Dr. Palak, over to you.
Thank you, Zach. I will just share my screen. Is my screen visible?
Yes, it is. You can start.
Good morning, everyone. At the outset, I would like to thank AIOS and all my colleagues for this wonderful idea and this opportunity. The topic that I would be speaking today is role of phakic IOL practice in a beginner's refractive career. So since morning, before me, two people have already spoken how tough it is fellowship and set up a new practice. So let us first speak about refractive surgery. Refractive surgery has been there since more than 30 years now, and it is continuously evolving field. If we look at the statistics, the single biggest cause of visual impairment is uncorrected refractive error followed by cataract, both of which are now considered to be a part of refractive surgery. So refractive surgery is no more a side dish in the plate of ophthalmology. It has become a mainstream branch, and also the fellowships are offered like that. Initially, refractive surgery was limited to corneal procedures, or I would say after that, laser-based corneal procedure. But no more it is so. Today, it has a varied procedures option available. It includes LASIK, PRK, SMILE, phakic IOL refractive lens exchange, and even the cross-linking. So when we look at a private refractive setup, the first thing which comes into play is finding the right location for your clinic, and also the cost which comes along with it. So it is very important for any new beginner to find the right place which is very well visible in the market and has a good location. And I'm sure any city offering good location to a doctor will cost a bomb for it. Now, the next thing after having the place comes the various machinery which you need to put up to have a refractive setup. So as Dr. Neeraj has already mentioned, these are the machines and the cost he has spoken about. And as rightly Dr. Zain also mentioned, that it is not only the initial cost of putting these machines which is a problem, but the AMC and CMC which follows it becomes a big hassle for the doctor to maintain these machines and keep the work going. After this, also a new beginner has to put a lot of effort, time, and sometimes a huge amount of money into marketing their practice. Because in today's era where social media plays a strong role, no patients come without having a Google review or seeing your page on the social media. So basically what I am trying to say is all this is that goes into putting a refractive setup for any new beginner. Now let us see what are the expectations when we put up a setup. What will be the doctor's expectation? He would want a good patient flow. He would want a good post-op result and minimum complication. And at the same time, also, he would look at a good income because he has put so much of efforts and time into putting all of this. Now, at the same time, when we look at what are the expectations from the patient, again, they want to go to a place where there is good patient flow. They want good post-op results and minimum complications. So I would say that these are the expectations which match between doctor and the patient. But the expectation where most of the things come into play is the cost. Patient wants all the surgery at the least cost with the best results and the best machinery. Now, in all this play of refractive surgery comes a role of phakic IOL, especially for a new beginner who has just entered the market. And it is not a good idea to put in a huge amount of money in buying laser machines and other associated machines to run a refractive surgery practice. Now, if we look at phakic IOL, it gives option to treat a wide range of refractive error and a wide range of patient profile. Now, if we look at the papers that have been published on phakic IOLs, a higher range of myopia, hypermetropia, and astigmatism all can be treated with these lenses. The candidates who are not suitable for laser-based procedures are also fit to undergo phakic IOL. Even the patients having stable keratoconus and wanting freedom for glasses, or I would say a better refraction or a better vision option, even post-corneal transplant patients, phakic IOL can be offered. So this particular option gives the choice to the doctor also and the patient also to treat many refractive errors and many conditions. Now, if we look at the side effects of any refractive procedure, as we would have heard, even after a good refractive surgery, many patients are unhappy because they suffer from a severe dry eye. And if this dry eye persists for more than 3 months, it starts affecting the quality of life. Then even if you have done a good LASIK surgery, the patient is going to be unhappy forever. And a new beginner cannot afford a single unhappy patient. Also, when we try to treat higher refractive errors on corneal-based procedures, there is decreased contrast sensitivity and associated glare and halos. Now, if we look at doing phakic IOL for such patients, it in fact improves contrast sensitivity. The occurrence of dry eyes is very less. It has stable results after the surgery. In this particular procedure, there is no removal of ocular tissue. So this becomes a reversible procedure and there is no damage to the eye caused. And also a good thing about this procedure is it preserves accommodation as compared to refractive lens exchange, which becomes a very important factor for the young patients who usually opt for refractive surgeries. Now, these were the advantages which we have in hand when we are doing phakic IOL. Now, let us also look at the economical viability of this procedure. There is no need of any special OT. You can do it in your own cataract OT, and also many instruments used for cataract surgery come into use for this surgery as well. There is no AMC which is hanging on your head, so you do not take wrong decisions. So, which may happen when you have a huge setup and you want to reach your targets. Nowadays, there are various economical phakic IOLs available in the market. So you can offer patients these surgery at a low cost too. So the IPCL or acrylic phakic IOL or the RIL lens from Appasamy, these are quite economical. Not difficult to master procedure, but I would say a proper training is must. The most important steps which are to be learned for this procedure is selection of the patient, IOL sizing, and loading. Other procedures, other steps you already learn in your cataract surgery. So it is not fast to learn it. Now coming to the most important factor is the wow effect, which comes out. So you are basically giving freedom from glasses to a patient who has not even thought of opening his eyes without glasses. The first thing with patients when they wake up is to find and search for glasses because they cannot live without it. So when you treat such high refractive errors, you get a greater publicity, you get a greater footfall, and also you create a niche for yourself in the market because not all untrained general ophthalmologists can this surgery. So to summarize, if I take IOL, it is a very good option. I would say low to high refractive errors, all range of patients. It is a safe and reversible option. It is relatively easy to master, economical, viable option for the beginners who have just come into market to start their refractive practice, and also gives a wow effect to the patient and the doctor both. Thank you.
Thanks, Dr. Palak. So excellent talk. You made some really good points over there on quite contrasting to what Dr. Neeraj has presented. So totally agree that phakic IOLs are very economically viable. Any of the panelists have anything to say? Any comments, any questions?
So I believe that, like you said, it's completely contrasting to my talk, and it was put in a very good way, in a very different way. And I myself perform phakic IOL surgeries, but the only problem I faced with patients when counseling them is that the cost of phakic IOL surgery is almost 4 times that of the cost of LASIK for both eyes. So there's a lot of hesitation from these patients to shell out that amount of money. Of course, in such patients where you cannot perform LASIK, you have to, that's the only option they have. But for a primary procedure, I feel a lot of centers are now, like she said, that the biggest headache is to take the patient to another center and operate LASIK. And in phakic IOL, you can perform it in your own center. But the cost factor is something which a lot of patients don't opt for phakic IOLs. That's what I wanted to say.
So I would like to say that when such a problem comes, you can counsel the patient in terms of that when you are performing phakic IOLs, there is no ocular tissue loss. When they hear this thing that you are not removing anything from their eye, in fact, you are putting such a thing which can be easily removed, then I think it becomes more convincing for them.
Yes.
And if you tell them the advantages that it is a reversible procedure and it is more stable, it would give you better contrast sensitivity, all these things, I think it's the way you counsel the patient that makes a difference. And coming
Definitely,
to the cost
I think
issue,
reversibility is one of the biggest factor which I
no
would,
loss of ocular tissue. I feel when you are not removing anything from the cornea, that also becomes a good point to explain the patient. And when it comes to the cost, I feel if the patients who cannot really afford, you can offer them Indian lenses because they are at much lesser cost than the foreign. And those patients who can afford, they themselves want costlier surgery and costlier lenses.
very true.
Yes, Indian lenses are not very less expensive than the imported. Slightly, I would say slightly.
Yes.
And see, there is definitely, I would say, a much steeper learning curve for phakic lenses compared to LASIK. But Dr. Palak, in your opinion, do you feel that the learning curve for a microkeratome is as much as that of a phakic lens? Because some people really find microkeratome also difficult.
Yes, so I would say in microkeratome, the biggest thing is if you are properly learned the sizing of that ring, which is very important because it is very difficult to handle the flap complications when they are there. So I won't compare both the procedures and the learning curve because those who are once set on microkeratome, their hands are set on microkeratome, it becomes very easy because after all, it's a machine's job. You don't have to do much. ICL, yes, it requires surgeon skill. You cannot deny that fact. And you cannot underrate also. So basically, phakic IOL is not replacing corneal procedures anywhere. It is just a good option when you don't have much in hand. As a beginner, when you don't have your own center, own setup, you can offer this procedure to the patient and still do it at your own setup.
So you are saying, suppose you get a patient, 22-year-old patient who comes to you with a -3.5 diopter sphere number. What would be your counseling strategy if you are at a center without a LASIK setup? Would you counsel go for phakic, or you would, advise them?
Yeah, if it is 3.5 diopters, I would give them option for both corneal procedure and phakic IOL because every patient who walks into your clinic with such a power trying to get refractive surgery is well aware of everything. So you cannot just not counsel on the corneal procedure because they are well aware.
I think it's a completely different IC then, and we should probably debate on this on a larger scale because if you the question that you asked is a very interesting one. See, there's also a factor of invasive and non-invasive. Of course, you burn the cornea, but you are actually making an incision. So it's a very vast topic, and we should plan something next time on this as well. Yeah.
One thing on the learning curve, as I personally feel that if you're a good cataract surgeon, your skills of cataract surgery are thorough. The learning curve really becomes very easy here in phakic IOLs. And on the point which Neeraj you mentioned about the cost factor, patients may not opt for phakic IOLs, they being expensive. There might be two sides to this point. There are certain patients who have been having high myopia, high glasses for so many years, do opt for it. They don't think twice before. If you give them that, if you explain the wow factor easily to them, you give them an idea about the results post surgery, they should opt for it.
Absolutely. Yeah.
Yes.
One more point is that in phakic IOLs, I feel like in corneal procedures, like we need to know in detail about different types of surgeries like contura or those wavefront guided and all those things. That all headache is not there in phakic IOLs. There it is either toric or non-toric. So that also the decision making becomes easier for the patient also, rather than the patient having so many list of things to choose between for LASIK.
With due respect, may I request our doctor to please go ahead with the next speaker so that we have good time for discussion towards the end. Thank you.
Okay. So now we have Dr. Ravish, who's working at Vaishnav Eye Care and Medical Center. He's at Navi Mumbai, and he's a good friend. He will be talking to us on translating my fellowship training into private practice. Ravish, over to you.
Yes, first of all, good morning to all. Thank you, Zain, for making me part of this wonderful IC. I thank AIOC as well for organizing it so well. Really wonderful inputs from my colleagues, Prajakta, Neeraj, and Palak. It's actually a daunting task to start a refractive practice. Here in my topic, I would be discussing on how I could translate my fellowship training into a private refractive practice, or rather, I would say how I could give it a start. First, before I begin, why I chose refractive as the subspecialty. Obviously, it was out of interest. There's intense patient satisfaction here. It's a lucrative branch that is not only money-wise, also it is clinically rewarding. It's worthwhile and fruitful. There's not a steep learning curve here, and also it can help build your cataract results. Then the fellowship happened. I was exposed to almost all the machines available for a pre-op workup for a refractive surgery, right from OCAS to the abrometers, the commonly used pentacam, the dry eye machines like SBM and all. Having learned all this, it really became like a daunting task as to how I was a bit lost as to how to apply all of these to my practice. I had few queries in my head, like whether should I join an eye institute? Should I have few attachments as visiting consultants in few places? Or rather, should I jump into a private practice or maybe a group practice with my colleagues? The last two options was a difficult task considering the finances. So I opted to join an eye institute. It was a simple math, more the volume of patient, more the refractive exposure. I started screening the patients planned there for surgeries. I screened the LASIK pre-op patients. I started assisting the surgeons, attending their OTs. I observed a few phakic IOLs also. As we discussed, a phakic IOL could be a good, viable and economical option to start with as a refractive surgeon, considering the cataract tools what you presently or you currently have with you can be used for the pre-op workup. As a fellow, I always learned that how dry eye could play a major role in the refractive outcome both pre and post surgery. So I regularly screen patients for dry eye at the institute. I checked their OSDI scores, I documented them. I had ocular surface analyzer at the disposable, so I used it for my patients. I noted their reports. Clinically, I checked for T-Bird, Schirmer's, and especially vitamin D values in chronic dry eye patients. I followed them up and I always maintained a Excel sheet about the progress of each patient. Then gradually I moved on to doing LASIK. It was not easy. I always made sure that the scans which were done are done correctly, as there's a very small margin for error when you're starting afresh. I took help from my chief mentor there. They stood by me while doing the surgery. I discussed my doubts with them. One thing which I followed was I always motivated my patient and never forced them for surgery. As you never know, it might be a bad day and you end up regretting it. Then I grew my practice. I moved on to being a visiting consultant in few of the places. I chose few multi-specialty hospitals to join as a visiting consultant. This was my first step towards a private practice. I wanted to keep my options open. I wanted to cater to more patients. Also, the ophthalmic and the non-ophthalmic medical friends at the hospitals at such multi-specialty setups can act as a referring source for your lasers. And also you can make a name for yourself here. This becomes a very important part while you practice in such institutes, such centers. You have to do in-house marketing. What I did was I left few patient information brochures at the reception at the waiting areas. I trained a couple of staff to counsel the patients in my absence. A basic information about the refractive surgery, I gave it to them, which they could give it to the patients. Population survey is very necessary. It becomes an important part where in the area where you're practicing, you need to know about the strata of population, what you're serving to. Also the target population, which will be served by you. So conduct workshops and webinars regularly. Educate the general public about the options for refractive surgery. You might just start with a regular webinar talking about eye anatomy per se, and then slowly moving on to refractive surgery and so on. It's important to break the myths. People sometimes come with very stupid doubts about refractive surgery, they have the commonest doubt what they have about a recurring or the regression of number. So you have to explain each of it properly to them, make them understand the surgery. Okay, in today's world, social media plays a very crucial role. I would say, it's the thing which will connect you with the people. So Facebook and Instagram, such medias have to be used judicially and to the fullest so that you can connect with people and talk to them. Cataract surgery can work the other way around also. It can help you boost your refractive practice. That is what I tried to do. I worked on my cataract surgical skills. I tried to aim for 6x6 for my patients so that a happy cataract patient would eventually refer or by word of mouth spread across and may help you grow your refractive practice. As in how you begin your LASIKs in your private, you have to do a thorough pre-op workup. You have to mark a machine which you are completely thorough with. As Neeraj already pointed out, investing in a machine might be a daunting task in the start. To start with, you might referring your patients to a tertiary center or the center where you're planning for the LASIK. You can get the scans done there. It is important to know about how to be able to do the scan yourself, and also you should be able to thoroughly read the maps. Always discuss with your colleagues whenever in doubt. if you're not sure, don't ever touch the eye. It's like rather lose a single patient than losing few patients. This becomes an important part. You should have a maximum chair time here, the counseling. You have to clear each and every doubt of the patients. Don't give them false hope. Try to know what they have it in their head post surgery. Explain the procedure, what you're planning for them in brief. Just a general overview is necessary. This is something a personal choice. I had 2 centers at my disposal for planning my for doing my laser surgeries. One was close to my private practice, the other was farther away. This was as per the patient's convenience. I kept. In today's world, it's very important to be seen and to be known. So you need to present papers, you need to attend conferences, obviously virtual conferences as of now, physical whenever they start. And you also have to update yourself about the recent advances, because you need to grow your practice. And this is how this practice, your refractive practice, can grow, by attending conferences, learning newer things. And so before I end, few pearls for efficient practice. There has to be a standard workflow in your OPD setup. The patient, right from being greeted at the reception to being sent off after the scans, after being able to be counseled. There has to be a documentation of each and everything, right from the complaints of the patient to the refractive error to the scans which were done for the patient. A prior history is also important here. You should monitor the flow of the patient from your cabin to the scans, and whether all the scans have been done properly. There has to be a good communication between you and your staff. And also the resources which are available to you should be utilized very efficiently. Thank you so much.
Dr. Ravish, that was a very good talk. You've made some excellent points. I think, a young surgeon who's finished fellowship does need to take away some points from this presentation, because what you said makes a lot of sense. You can't just jump into doing LASIK or refractive surgery as soon as you come out of practice, and you can't afford to get disillusioned by the fact that you're not getting patients. So whatever other small things you've picked up from your practice, like doing a good dry eye workup, screening patients for keratoconus, this non-surgical part plays a very big role, and you very well put across these points. Panelists, if you all don't have any questions, I think we'll go ahead and we can have a discussion later. So I'll be going next. Okay, is my screen visible?
Yes.
Okay. So I'm going to deal with a very interesting topic, something contrary to what most of my colleagues have spoken of. That is, can a fellowship untrained ophthalmologist be a successful refractive surgeon? Just give me a minute. Okay, so this is really a pertinent and practical question to us today, because although most guys are fellowship trained, there are a lot of fellowship untrained ophthalmologists who just venture into refractive surgery, and some of them are successful, some of them are not. It's a very complex question, because there are many layers to this. This can only be this question can only hold for refractive surgery. You can't have it for something like oculoplasty or some other specialty where you actually need to be trained. But because refractive surgery has such less not so much surgical skill required, a lot of people venture into it without having a formal training. What is needed to make a good ophthalmic specialist? Not refractive, just a general good ophthalmic specialist. You need to have a good subject knowledge, you need to have good clinical skill, and you need to have good surgical skill. These three are needed to make a good specialist, and obviously you obtain this from your fellowship training. But how does a good ophthalmic specialist become into a successful ophthalmic specialist? I think my colleagues have stressed enough on this. If you own your practice, you have to be able to market yourself to your patients. If you are a freelancer, you have to be able to market yourself to doctors. And if you have a fixed job at a tertiary center, you need to have all these traits of being hardworking, passionate, having an academic interest, a teaching interest. But how is refractive surgery different from other specialties? Okay, for one, refractive surgery is never given importance as a standalone field. It's always with cataract or cornea or something else. It's an ironical branch because it's a purely surgical branch. You don't have like a medical management in refractive. It's purely surgical, but at the same time, it is not very surgically demanding, and it is very heavily industry driven and investment based. So this is how it differs from other branches. So generally, you don't get a fixed job at a tertiary center if you are into refractive surgery. So you have to basically be able to market yourself to your patients well. And the biggest question mark is whether fellowship training is needed or not. So yes, people can argue that there's not much surgical skill to master, but there are a lot of aspects of refractive surgery that do need training. They need formal training. So the surgical training part is needed, even though it may be less. You do need to train yourself in microkeratomes and doing smile, in handling intacts, and there are so many surgical procedures that come under refractive. Counseling and dealing with unsatisfied patients is something that you don't learn overnight. You can't just start off by doing LASIK and not knowing what to do when they come to you. You need training. You need to have seen these patients in and out. The surgical planning part is one of the most important aspects of refractive surgery. So you need to plan well for a good outcome. And we are dealing here with patients who are very anxious and tolerate zero margin for error. So you cannot afford even a minus 0.25 or minus 0.5 error. So you're dealing with such patients. So these are the aspects that do need training. But unfortunately, there are a lot of limitations that current refractive surgery fellowships offer us. So for one, the institutes that offer pure refractive surgery fellowships are far and few in between. So I can't think of too many, at least in India, which offer pure refractive surgery fellowships. And the ones that do offer, very few of them actually give you surgical work. So they'll give you everything, planning and all. But then, if you want to learn how to do a smile, not many centers may teach you how to do that. A very important question that has to be asked is, does a fellowship teach everything? Okay, so you can't, do a fellowship, not learn how to do a microkeratome and then come back into practice wanting to, again, learn microkeratome. You've spent 1 year in a fellowship and, you still need to learn a microkeratome is something that, according to me, is not acceptable. A fellowship should teach you everything in refractive surgery, and I don't think many fellowships teach you everything. And another important factor about fellowships is that after you come into private practice, you realize that you can't replicate everything that you have learned into your private practice. So, you suddenly feel paralyzed or handicapped that, okay, I had this tool for me to screen this patient, but now I don't have it. What should I do? So these are the limitations that current refractive surgery fellowships offer. According to me, it may not be as beneficial as it seems doing a refractive fellowship. So if you don't do a fellowship, then how do you train yourself in refractive surgery? One very important way is learning from the industry. Okay, so your industry engineers, the people who supply your excimer laser machines, they are very good teachers. They know everything, right from the anatomy of the cornea to how it will respond to how the machine does things, and they keep workshops so you can learn from the industry. If you're a good cataract or anterior segment surgeon, you can become a good refractive surgeon, as Dr. Palak has already spoken about. Because if you're a good cataract surgeon, you can start practice with, phakic IOLs. So if you have a godfather, mentor, teacher, these are the sort of people who can help you. If you have a practice, like in my case, my father is a practicing refractive surgeon. He has taught me a lot of the small, finer aspects of refractive surgery. So this also definitely helps. Even if you don't have a godfather or mentor, you can just go and observe established surgeons. And trust me, in refractive surgery, observing established surgeons in your area, how they deal with patients, does make a big difference. You can learn a lot. And you should not miss the opportunity for a good conference or a workshop or even a CME. There are these small CMEs which come and go, from which you can learn so much. You can interact with people from other places, how they go about their work. And these are all the ways, according to me, how you can, learn refractive surgery in spite of not doing a formal fellowship. So then why should you do a refractive surgery fellowship? Well, if you want to publish and make a name for yourself in refractive surgery, I think doing a fellowship is the only way you can do that. if you have an eye on the center, no center is going to hire you as a consultant. So if you do a fellowship at the center, you become an asset to the institute. The institute doesn't want to lose you. You can use that as an opportunity to actually work at the center and make a name for yourself as a refractive surgeon at that center. And also, if you are interested in learning everything about refractive surgery, even if it means not able to replicate that into your practice. So yeah, there are people who want to learn everything and then decide whether they want to implement that in their practice. So these are the reasons why you do a refractive surgery. But when you do it, you should know exactly what to expect. As I have said, do a proper research and then go in for a refractive fellowship. What you shouldn't do is you shouldn't start a refractive practice thinking that there is no skill involved. Okay, so that is absolutely a no-no. There are a lot of people, retina, glaucoma, oculoplasty guys who say, okay, I'm bored of what I'm doing. I'm going to buy an excimer laser and start refractive surgery. And it's not going to work. Or, you have to be very lucky to make that work, because it's really difficult to deal with patients, to deal with complications afterwards. You need some sort of training before you start. Don't do a refractive surgery fellowship just for the heck of it or for an extra degree. If you're truly interested only in phacoemulsification or cataract, do a phaco fellowship. Don't do phaco refractive, because you are disrespecting refractive surgery. There's a lot to be learned and you won't be doing justice to that part of the fellowship. And don't just take a fellowship because you want to work at the institute without having an interest in the brand. So many people just want to work, say, in LV Prasad or some other big institute, and they just take the field without having an interest in that. So give it the due it deserves, because refractive surgery, you have to respect the field whether you are trained or not. And trust me, there is a lot to learn. There is LASIK, customized treatment, keratoconus, phakic lenses, presbyopical. There is a lot to learn. It's not like just as what some people think, very limited. There's a lot of scope. So my final thoughts, my answer is yes, a fellowship untrained ophthalmologist can be a refractive surgeon, provided you follow the points that I have said. And if you don't have a fellowship, you can always do FICO if you feel that you are skilled enough for that. If you need an additional certification, the All India Ophthalmic Society gives you this opportunity. And yes, so that is what I have to say. So thank you.
Excellent talk, Zen. I think our mentors and gurus never did a fellowship and they learned it the hard way. So you put that thing forward in a very nice way. Also, one more small point that I really liked from your presentation was the fact that you have asked everybody to adapt to different machines, because a lot of us face this issue of getting adapted to machines which we have never seen. So in fellowship, you have all the high end and top of the line machines. And when you come back to private practice, you see that those machines are not there and you get paralyzed, like you said. So good talk, Zen.
Also, I think he mentioned a very good point about, observing senior surgeons or established practitioners. It's not just about the surgery itself. It's just the whole before and after and how they manage their refractive suit and, handling the patients and what goes into it as a complete surgery, not just the whole 15-20 seconds of hitting the laser, which is very important. You learn a lot of things by just observing how they have done and been consistent over years.
I think, Ronak, we'll have your presentation and
Okay.
then we'll have a good 10 minutes for discussion after that.
Okay. Yeah, hi. Good morning, everyone. Is my screen visible?
Yes, visible.
Yeah, hi. So I would like to thank AIOS and Dr. Zen for giving me this opportunity. So I'll be talking about marketing your refractive surgery practice as a newbie in the field. Okay. Basically, what happens, you have just finished your fellowship and your training and you have decided to start your own practice as a refractive surgery consultant in the city. What are the things you can do to successfully establish a surgery practice amongst the already established practices that you have around you over the years and have been attracting patients? Outline for the talk is basically we will discuss about how having your own setup, getting attachments is helpful. Generating an initial patient database is very important. Then there's a strategy to follow about after you get your patient database. Then are a few tips and tricks for marketing yourself, your practice, targeting the right population, which a lot of people miss out on. And of course, as my previous colleagues have mentioned, updating yourself with the latest technology is very important. Basically, post training, I would suggest that, initially you can just join an established practice in the and learn how private practice works before venturing out. It teaches you a lot of things about the non-surgical part, where, how to manage counseling, convert your patients, retain them, retargeting them, remarketing to these patients and their family members. Because sadly, when it comes to refractive surgery, there's no concept of visiting doctors. You will hardly see refractive surgeons as visiting consultants, because most of them have their own centers and they do it on their own and they don't require other doctors to come. There's a concept of visiting patients. So the center, because the cost of putting your own infrastructure is very high. Initially, the most important thing is creating your own patient database. Once you start this, the other things flow. Sometimes it has to be at the cost of increasing revenue, having to give out discounts or having introductory offers. Having a healthy patient base ensures organic growth, which is actually the most important thing. Like, for example, today's refractive error patient, someone who walks in at 16, 17 years of age, will be a few years down the line your own LASIK patient. So treat them well. Cataract patients, they get you everything. They'll get you sweets, they'll give you blessings and goodies, and sometimes they even get you refractive surgery patients. Even your pediatric population, who are, initially very shy and coy, but over the years, since they have interacted with you, they have a trust in you. When the time comes for them to take up a surgery, they will not look anywhere else. There is something called as a 3M strategy, where, you master your skills, then you market them, and then there is a management of the patient. So these are not independent strategies. They all co-dependent on each other's. Mastering your skills is most importantly, you better be a good surgeon. There is no second opinion about that. You must know the latest technologies and used and the treatments offered. And you should have the experience to do it well independently and managing complications if they are. Do all your training and then take them to the next level of market. There's no point, having a Ferrari or a better car and then not knowing how to drive it. There is something called as management of the patient, not clinical management, but the management of the patient in your clinic itself. What happens is it helps you convince them to go ahead with the treatment you have offered or explain to them. Your staff training, behavior, counseling of the patient, the general experience in your clinic is what helps you achieve that goal. Remember, marketing can just help you get sufficient patients the waiting room, but managing that patient and his experience will get him under your knife or the laser. So a few important things are like, just invest in a topographer, patient education material when they visit your clinic, so that they are informed about the procedure. Not everyone knows what a contour is. Everyone knows what LASIK is probably, but they may not know what a smile or a contour is. So it's your duty to inform them at least, so that they will have an informed choice. Then your counseling, either you do it or you have a counselor at some stage in your practice, and it helps. Then comes to the marketing aspect of your practice. Marketing gets you sufficient footfalls in your waiting room. So nowadays it's very easy. You can do it from the comfort of your clinic or your home. It doesn't require you to spend a lot of money if you do it very smartly. So a few weapons for marketing are, we can talk about them as activities, personal branding, your videos, social media marketing, which plays a very key role, friends and family schemes, and there is a referral system with other doctors, which we will touch upon. So initially, as a new refractive surgeon competing with the established practices, you can start off with camps and general screening camps, and nowadays you have refractive surgery screening camps. Best target population, I feel, is corporates and banks and IT offices and college students, because these are the age group who are most likely to consider refractive surgery as an option. There are some, I even know someone who has tied up with community matchmakers to refer potential brides and grooms for their classes. It's just weird. Some networking platforms like BNI and influencers on Instagram and Facebook, you can just do live and get your presence noted. That comes under personal branding also, where you can just join community events, camps, your doctors federation meets, like how we have informed the MIRSA, where we help each other independently when someone requires a scan, the closest scan center or laser surgery platform required, and other things. So there are a lot of things you can do, and you can make your presence felt at conferences by giving talks and lectures in your local IMA and all those things. There are people who can dance at weddings. You can just at least talk about how trained you are and what services you offer. Of course, if you can try getting on the Kapil Sharma show too. Coming to videos. So this is a part of social publishing instead of social marketing. What happens is making good patient education videos, they help build trust in the doctor. They validate his or her views. They alleviate the patient's doubt and fears towards surgery. Before and after videos, patient reviews, experience, treatment modalities. For example, I give you this example of a doctor from Mumbai. This doctor has a subscriber base of 2 lakh subscribers. His reach is almost, you can see, he's got 1 crore views on his thing. He's given an example in a lot of marketing talks and how he's purely marketed his practice based on YouTube, which actually does not require a lot of money to be spent. He now gets patients all over the world just because of his videos. The people get referred just because of his videos. Coming to the big thing nowadays is the social media marketing. What platform to choose, which social channels are best, what should you post, how much time do you invest, all very relative things. So what happens is, why should you include it? Because it helps you build influence in a key area topic, attract newer patients, connect with your peers and patients, and it also drives signal to your website and your social media platforms with the help of SEOs and signals. What channels are the best? Like Facebook, Instagram, Google, My Business, YouTube, a lot of things. So everything has a different set. Some help you generate new patients, some help you build influence, some generate more and more traffic towards your practice. To start with, I think Google My Business is a very important platform where at least it is simplest, informative, and a few more things you can do with paid promotions and having reviews. Because there are a lot of patients who will search for the location and then they'll come and visit you, and they'll also read about some reviews. So reviews, are you getting the reviews on Google? It helps building trust, a lot of impression about the doctor. Even your negative reviews and how you have handled them and replied to them also makes a lot of difference. There's no point just neglect the negative reviews. It improves your search results. You can post introductory offers and new treatments if you have. Coming to Facebook and Instagram, now the sky is the limit. You post content, you create shareable content. There are more and more likes and shares, and you connect with a lot of people. Just a minute. Coming to Instagram, you can publish, know your audience, pay attention to insights. You'll know what kind of people are looking at your pages. Use hashtags. You never know what gets viral nowadays. There is, invest time in stories and reels and videos, because these are the things that push your algorithm. Something like a friends and family scheme, apart from social media marketing. So basically, my first few patients of LASIK were their grandkids who had accompanied them during the cataract surgery and subsequent follow-ups. Give them example how they can see also better and clear without glasses and undergo the procedure for their spectacle independence. Ask your patients to refer you patients, or they usually do it on your own, and give them referral benefits. It could be discounts, example, for their own surgeries. Works well since everyone benefits, the doctor, the patient, and the referred patient. So there were patients whose grandkids got operated, and then subsequently they got their girlfriends and cousins got operated with me. The referral thing is with your doctors of the other specialties and your ophthalmologist from other subspecialties, where a retina colleague sends you across a refractive surgery patient and you send him your retina patient for a surgery or something which you need. There are things like general practitioners. You can approach them, talk them, even explain to them about the latest treatments like Contura or something which they may also not be aware, so that at least they can inform the patients and then they can do it in their way. Other thing is, I will say that it's important to perform at neutral centers just to avoid the clash with the established practice. Feels the patient is under your own control. Investing in a topographer, I think, is an important aspect, because that is where you can hold the patient, explain, and take an immediate decision and counseling. Print advertisements, pamphlet, newsletters help to an extent. I think marketing is important. Just the last couple of slides. Most important is not to forget to target the right population. three types of patients. Some who are aware of Smile, Contour, and latest technology, they are least likely to come to you. They will go to the established searches on the Google. There's someone who just want to get rid of their glasses. So you can just explain to them and they will be very happy to listen to you. There are people who have no idea about something called basic surgery or PRK surgery for their high error, and they live with it for the rest of their lives. You can just target them. And lastly, you have to keep updating yourself with the latest technology like Smile and Contura or any other Streamlight and No Touch and Bladeless and all those things, because those are the ones that will drive the patients to your clinic and eventually give you outcomes that will matter the most.
Excellent talk, Ronak. You've put across some good points on marketing and really a lot of take-home messages from that. So I would like to ask you, when you have your LASIK patient or refractive surgery patient, once they are done and they are satisfied, on your final follow-up, do you do something? Do you tell them something actively? Leave a Google review or refer some patient or
Yes,
some.
yes, yes.
So
So I
you do.
definitely do that. At least a Google review, I do take a short video and it helps in posting it on because it sometimes just validates. Coming from the patient's mouth is a big validation. There's no point just writing it in a fancy way on your website with someone's name because it just doesn't create that impact. When the patient gives you a wow effect and how you have changed his life, there are patients who will elaborately discuss about, I've lived it for the whole of my life and now I'm spectacle free. It's just an impact. Okay. Also, as I told about the friends and family referral scheme. So there are patients sometimes they have told me that, doctor, my friend wants to also do it, but he doesn't know what to do. I'm like, you can get him here. And then eventually some of them ask for discounts, you give them because what happens, they are feeding you a patient and a certain amount of discount acts as an incentive for them also. What happens, at least their pool of friends and family will not venture to another doctor because they have seen this guy get operated with you and his results are good. So they will be the first person to ask them that how was your experience with Dr. Ronak or Dr. Zen, so and so. And they will take their word and eventually they will get to you without you having to do much, apart from just convincing them to refer them, something like that. It really works.
So we have 6.5 minutes for discussion. I request the other panelists, to ask questions and we can have a discussion on all the topics spoken about.
I wanted to ask one question to all you panelists that what was the average time since you started your practice? What was the average time you had to spend before you got your first LASIK patient? LASIK or any refractive surgery patient?
Basically, I think I started newly in the lockdown, just before the lockdown. I think 3 months down the line when, there were a few, as I told you, my first 5 or 7 patients were all grandkids of someone whose cataract surgery I had done. So fortunately, it worked out slightly earlier. I don't know how it was for others. Of the direct patients who came were after that initial patient database was there, and the word of mouth spread that, okay, this doctor has his own OT.
So that's what I just wanted to say that now, once we start marketing ourselves as a refractive surgeon,
it won't be your first surgery, I'm sure, in your private practice.
Definitely. So on an average, what is the average time that is required for you to get?
For me, it took around 2 years to get a first LASIK patient post my fellowship. It does take time. You have to convince people, as Ronak pointed out, you have to do good surgery, maybe not the refractive one, the cataract one, so that they could refer to their relatives, their grandkids and all. So it does take a while, but for me, it took around 2 years. One more thing as a newbie, what I would like to add is you can have certain the publications, the papers, what you present, the awards, what you get in the conferences. Those things could be displayed in your OPD setup so that patients in the waiting area when they're sitting, when they're waiting for their turn, they could have a look. Patients do notice all this these days. So this could also act as a way to publicize or market your practice.
I think the question is very subjective because, like you said, like Dr. Prajakta said in a presentation, to each his own. I was lucky enough to get my first LASIK patient within a span of 1 month because the center I joined had a LASIK, and I joined there as a visiting consultant.
Start your practice as an institute, then probably you take some time as a your private practice. You might do it earlier. And also depends on
How
well you're
vigorous are you
talking
in
to
marketing? It depends on how vigorous are you in marketing yourself in the beginning. Like Ravish said, even I had done the same thing. I had given pamphlets at the reception or at the charitable center I was working. So I thought maybe even though it's a charitable center, I may get some patients. I had spoken to a few optometrist friends of mine that if you have any patients, please refer them to me. So it's a very subjective question, and it all depends on your efforts, how
Yeah.
quickly you get patients.
So what I
I
want to
completely
say
agree
is,
with.
yeah.
May I finish?
So, yeah, Ravish, go ahead.
Sorry, Join. I completely agree with Neeraj. I too worked at a charitable center. The center didn't have a refractive center. I mean, a refractive setup, but I had few people walking in who used to inquire about the LASIK options around the center in the vicinity. I told them about me being a refractive surgeon. You shouldn't shy away from giving your phone number sometimes. I did that. I gave it few
Correct.
numbers to my friends who used to call me back later, and I could take it to a center where I could get the scans done and they maybe do a surgery later. So in the initial period, the more you communicate with the people, the more you talk to the people, the more available you are for them or approachable to them, it helps you grow well. Actually.
So, on this matter, what I feel is that there's a thin line. You shouldn't be too pushy. In the sense, see, giving, marketing yourself aggressively to patients who you have already operated, like as Dr. Ronak said, your cataract patients are a very
already
good
have a trust
population to
in them,
target.
and then it's
Yeah,
really
but just if suppose you opened a new clinic somewhere and around the clinic, if no one knows you, if you just go on giving pamphlets saying that you are a refractive surgeon who does LASIK, I think that doesn't work. But your optometrist, your patients, existing patients, someone who's seen you operate, so patients think if you're a good cataract surgeon, you are a good comprehensive ophthalmologist. So targeting these people does wonders.
So
I
that's
honestly don't believe in hard selling yourself to just anyone around, because it just it pushes the patients away.
yeah. So hard selling is you don't push it. So what happens is the advantage of social media is the patients are seeking for you, not you. You just making your presence felt, which is not sometimes pushy. You're there and they will just seek out like that. So pamphlets and just keeping on talking about it everywhere about yourself as a different, that is pushing it, which I think is now an obsolete pattern of pushing yourself with pamphlets or distributing or talking all the time about it. Make your presence felt in the smart way so that patients who are seeking get to you instead of you getting to them.
Yes.
Biggest publicity is word of mouth. One good LASIK patient will get you 4 good LASIK patients, 4 more LASIK patients.
Yes.
And I feel the biggest way to market yourself is, as Ronak said, put patients' reviews. And if you have your own page and all, constantly putting educational stuff and making people aware, that is where the difference between being pushy and marketing yourself comes. If you are telling them what is good for their eyes or how it works when they are on screen, something like that, then they want to come to you and listen more about it.
Yeah, because you're just elevating their fears and doubts.
Exactly. Yeah.
At the same time.
Yes.
True. So I think we've kind of come to the end.
I just wanted to ask one more thing to Dr. Palak. I couldn't ask at that time. So when you do phakic IOLs, do you really feel the need to have an optical biometer or at least a post-op evaluative tool like an ASOCT to check for vaulting and other angle structures? And how pre-op optical biometry will give you more confidence over your immersion for axial lens and anterior chamber depth?
So Ronak, I am from Nagpur. So here everyone is not having those big machines, and like in Mumbai, we don't have too many centers where there are such machines. So yes, people are doing phakic IOLs without having OCT, without having optical biometer. But since I am fellowship trained, I wouldn't advise doing that. And I would stress on the importance of having optical biometer and having post-op OCT to see the vault. But people do good results. I'm not saying that they are doing anything wrong. They they do a good job, and their clinical judgment is good, where they can see what on the means whatever decision they make on the basis of slit lamp only, that works for them.
Correct. So
But
sometimes judgment is important.
Okay, so I think we've run out of time.
Good point, actually.
I thank all my speakers, panelists for joining me in this IC, and I hope it was useful for the audience. Thank you, AIOs. Thank you, Mr. Himay, for giving us this time, and we'll sign out.
I'll
Thank you.
like to take this opportunity to thank Dr. Zain and also all the speakers for sharing their time on the virtual platform. It was great having you here. I hope you enjoyed the session.